Testing, testing. Around 3 years ago, a close family friend of mine developed a bacterial infection that eventually led to the amputation of his fingers. At the time, I didn't understand how something like that could happen, but later I learned that the underlying cause was antibiotic resistance, or ABR. After speaking with Dr. Neil Naik about how these cases typically unfold, I want to illustrate what ABR can look like through a patient scenario. Meet Erica, who is experiencing symptoms of a urinary tract infection. So she goes to her doctor, who prescribes an initial antibiotic and sends her urine sample to the lab for further testing. While Erica is starting her medications, lab tests are being performed to determine what kind of bacteria she has and which antibiotics will be effective against them. 3 to 4 days later, the results come back, and the doctor realizes that the initial antibiotic he prescribed will not be effective against her bacteria due to resistance. So he calls her back in and adjusts her therapy accordingly. But during this entire time, Erica's health may have worsened, and precious time and healthcare resources were wasted. So as you can see, a problem like this has an impact on our sustainable and health futures.
The scale of this problem is huge. In 2019 alone, there were 4.95 million deaths associated with ABR globally. That's almost 13,500 deaths per day. And this burden continues to grow. By 2050, it is estimated that ABR could cause additional healthcare costs of around 1 trillion US dollars. And by 2035, resistance to last resort antibiotics could double, further shrinking our treatment options. Let's narrow in and look at a specific type of infection, such as a UTI. These make up 15% of global antibiotic prescriptions, yet 47% of initial prescriptions are inappropriate. This is because doctors often have to prescribe antibiotics empirically without having resistance information available to them. So when the first antibiotic fails, patients are required to switch their treatments. This alone costs around $2,000 per patient. And if a patient like Erica was to receive her test results within the same day, this would reduce treatment costs by 40%. So to address the problem, it's important to understand the underlying mechanism. So a specific yet very prevalent type of resistance is caused by ESBL enzymes. These are present within bacteria. They essentially break down antibiotics, making them no longer effective. So in 62% of ESBL cases, the first antibiotic fails. So this highlights the need for rapid diagnostics for detecting ESBL-related resistance.
To understand the current challenges of antibiotic resistance, it's important to look at how this problem evolved over time. In the 1940s, penicillin became widely available. This greatly improved the treatment of infections, but it also gave an advantage to bacteria that could fight the drug. Resistant bacteria continued to multiply while sensitive bacteria died. Over time, resistant strains became more common. In 1966, the Kirby-Bauer antibiotic susceptibility test became the gold standard for detecting resistance. However, this method requires expensive laboratory equipment and 3 to 4 days to obtain results. A major turning point occurred in 1983 when scientists discovered the first ESBL. This greatly reduced the effectiveness of many first-line treatments. By the 2000s, ESBLs had spread globally, and we began to see these infections not only in hospitals, but also in the general population. In 2015, the WHO formally recognized antibiotic resistance and launched the Global Action Plan in order to combat this growing threat. This highlighted large gaps in resistance testing and surveillance, especially in underprivileged areas.
So as mentioned previously, the current standard of ABR diagnostics is cell culture-based testing, which requires specialized labs and takes at least 3 to 4 days for results. And there's been many attempts to try to reduce this diagnostic gap. Starting off with commercial products, the two examples that you see on the screen here are color-changing assays that indicate the presence of ESBL enzymes, kind of like how a pregnancy test works. However, they're only meant for clinical labs because they rely on bacterial cultures that need at least 24 hours of prep. Moving on to established works in literature, the 3 examples on the screen here all use different techniques to detecting ESBL enzymes. However, they require costly equipment or specialized software, trained personnel to operate them, and they're still time-consuming. Now, building on this, it's important to recognize that ESBL prevalence is approximately 3 to 5 times higher in low-resource settings, and this is due to factors such as poor living conditions as well as antibiotic overuse. So to summarize, the previous attempts at detecting ESBLs fall short, primarily because they still require long testing times and they're not intended at the point of care. And all the gaps that you see here on the screen contribute to barriers for effective antibiotic resistance, not only in Canada, but in low-resource settings. So looking ahead, the future of antibiotic resistance is scary. By 2050, ABR is projected to contribute to 10 million deaths. which is the same number of deaths caused by cancer in 2020. And this highlights the need for effective diagnostics, saving lives, money, and healthcare resources. Thank you.
Maybe you should still have control over that. Thank you so much to our first pitch, ABR Resistance or is that ABR Detect? I'm so sorry. ABR Detect for your pitch. We will start Q&A with the judges now. Is there a judge who would like to begin? Who has a question ready? True, and there's a mic there that you can use.
Hello?
Yep, perfect.
So I have a question. So in terms of the detection of these antibiotic-resistant strains, have you talked to frontline healthcare workers and asked them what their problems with the current solutions are?
Yep, so we did speak. I can go to the first or second slide, had a picture of Dr. Neil Naik, he worked in Africa and he's also a family doctor here. And we talked about the current flow of how, like specifically narrowing in on urinary tract infections, because it does depend on the kind of infection you have. He talked about how it typically goes. And so Erica's case illustrates that. And so sometimes urine samples aren't even sent to the lab. So typically what might happen is that if I'm experiencing symptoms of a UTI, I go and talk to my doctor and he can do something called a urine dipstick test. So these are present in some healthcare settings, but not all. And what that is, it's like a color changing test, almost like strep throat swabs if you haven't had that done before. So they only detect the presence of bacteria. Specifically, they detect nitrites, which indicate the presence of the bacteria, but they don't give any information about resistance profiles at all. So they typically, you would prescribe a first-line antibiotic based on what you think like the community prevalence of antibiotic resistance is. And the patient goes and they take their antibiotics, but if the infection still stays after that and they come back, this is when like urine samples might be sent to the lab for further analysis to really get an idea of what kind of antibiotics you're resistant to and what bacteria you even have. So that whole process, you can imagine how much of an impact that has when patients still have their health worsening and the doctors don't have that information available in the moment so that they can give that initial.
To add on to that, we did also speak to another doctor who has worked in like underprivileged areas in the Middle East, and he even mentioned like not only there but in Canada, like you might have seen, we've also mentioned sustainable futures. One of the reasons is like here a lot of times like they'll prescribe a lot of antibiotics that are like more on the expensive side, just because like resistance is getting a lot more common for like those cheaper antibiotics nowadays. So if like if doctors were to find out that a patient is actually not resistant as well, then this would actually like help them from saving those saving them from like using all these expensive antibiotics, and they could use more cheaper ones like penicillin as well. So this would also reduce like any of that resource wastage as well.
Yeah, Alia, go for it.
Okay, so my question was around cost. I think you had a slide up there saying it was about close to $2,000 per case.
Sorry.
Is that correct? I'm just curious if you're able to dig into where exactly the biggest cost burden is when something like this happens.
Yeah, so this stat specifically talks about antibiotic switching. So this statistic here was actually a regression analysis done in the US where they analyzed sort of from like insurance records of patients as well as their cultures and like records of the bacterial cultures. If the treatment was to be given earlier, how much of an impact does it have on the cost? So this involves things like hospital visits, doctor visits as well. And specifically for ESBL, we didn't have the stat on the slide, unfortunately, but do you remember the one that you had? It was, so when comparing, ESBL versus non-ESBL infections, so not only is it the difference in like the amount of days that you stay in a hospital, for example, it's also the amount of money spent. So it was like $10,000 compared to $7,000. So there's a lot of facets to it as well, and there's different aspects to consider, such as whether or not like the patients, if they have any comorbidities as well.
Great, thank you.
Okay, we have time for one last question.
Sure. Okay. I think maybe that's closer to the problem statement definition here, right? So on the other chart, you're saying that the current commercial solutions aren't sufficient because of speed
Yes.
and presence of the patient.
Yes.
Is that right? Okay. What's okay, that's clear. What's happening in AI right now that actually might reduce the benefits of any potential solution you could come up with to this problem?
Sorry, could you rephrase your
Like
question?
in AI, like is
Yeah.
anybody have you seen anything out there
Yeah.
that anybody's working on that might lessen this
Yeah,
problem?
that's a really good point, actually. So I wasn't able to get a chance to delve deeper into these works in literature, but this one, for example, it uses color changing assays as well, similar to the commercial products, but using AI like algorithms, they're able to just taking a picture of it and it analyzes it quickly to tell you the exact concentration, or not like typically a rough estimate. So it's like a semi-quantitative sort of value of the types of concentration. So they have like 6 kind of like chambers there, all trying to detect multiple types of like ESBL enzymes and multiple types of resistance mechanisms. So this is really cool, but they still rely on culturing in order to grow the bacteria to the sufficient concentration that you'll able to actually get reliable results. So it's all about that culturing. So either you have really expensive and time-consuming methods that you don't need to do that culturing beforehand, or you have methods that require culturing, but they're quick. So like the actual color change happens in like 15 minutes, for example. Yeah, that makes sense.
Okay, thank you so much, Team ABR Detect. Very well informed.